Continue our discussion and case presentation of hard and soft tissue considerations. Definitely Dr. Kim's presentation sets a strong foundation for thinking about not just the bone availability, but what are the future consequences of implant treatment. And so a lot of that involves thinking about the prosthetic design. Where is the tooth going to go, and what soft tissue is going to be present around that future tooth to support the therapy. So not only day of surgery, primary stability is important. Yesterday we talked a lot about primary stability and mostly about surgical implant placement, but today and this morning so far we're going to be focusing on really like the finesse or the fine art of the soft tissue around the implant. So let's begin with some bone grafting. So these are just images from Google, but this represents where I'm from in Texas, in a small town of Waco. This is our college football stadium here on the upper right side, our water tower, and these images here, this is sort of a celebrity couple that lives in our hometown, and so they've helped our town grow and become more family centered and welcomed lots of businesses to our community. So we're in a growing community and we're very happy to be there. So talking about bone foundation and setting the stage for successful treatment is really integral to all facets of life, and you know I consider myself part of that area where I need a good foundation as a person to be successful in life. And so my foundation to me right now is of course my wife Christy, my in-laws and my mom and my sister and our two dogs and our church community. So this is my foundation and it helps me be successful, but we're going to talk a lot about bone foundation. So one way to think about bone foundation and bone grafting is to consider, you know, what type of graft solution is needed. Depends on the case that we're working on. Not every case will be approached the same way. As we saw, Dr. Kim presented some beautiful photos and cases of patients with varying degrees of bone deficiency or soft tissue deficiency, one or the other, or a combination of both deficiencies. So when we think about bone grafting, it could be this video here on the lower right side where we are doing an autogenous block bone graft in the anterior maxilla, and then 4 months later on the upper right side we're retrieving the bone fixation screws due to a deficient buccal lingual bone area in the anterior maxilla, or over here on the left side where we're doing the lateral window sinus floor elevation. These are all cases where we're considering bone grafting materials, and for me in my practice I like to keep things simple. You know, Dr. Ed was talking about keep it simple a lot yesterday and this week. So simplicity matters because of your workflow in your practice. If you have, you know, dozens of different types of bone grafting materials in your practice, sometimes it can feel like you have what you might call a choice paralysis, where you're not sure which material to use, which one is the best one. And of course it's good to be prepared for, you know, any cases that may require different bone grafting materials or methods, but I do follow the keep it simple rule, or what we call the KISS rule, and it just helps be productive in practice. So today we're going to focus on some more fundamental properties of bone grafting, and this is not as high level of a topic as what we've discussed this morning so far, or even yesterday, but sometimes it's good to remember the fundamental building blocks of what it is we're doing. So this should be a review for a lot of us, but sometimes it's good to review it together. So 4 different classifications of bone grafting. There's an autogenous, which is coming from us, allogenic, which is coming from the same species but a different donor. Xenograft is from a different species, and synthetic is going to be created. So there's 3 different properties to consider, and not all 4 types of bone grafting categories have all 3 of these potentials. And with osteogenic potential is something we're very interested in. We want to be able to generate bone. Also, osteoinductive potential is going to be something we consider with allograft. And osteoconductive potential will help us create a foundation or a matrix to build bone and have a pathway of where to grow the bone and to accelerate bone formation. So some basic properties of autogenous grafting is historically been considered the gold standard, and for a lot of good reasons. We know that autogenous bone is highly accepted because it comes from the same patient. And so technique is important to consider. The first slide that I showed, you saw a couple of videos where we use block grafting on the anterior maxilla, and we were placing those screws that you saw me placing into the bone, and then in the upper right video I was removing those screws. Those screws are important because we want to immobilize the bone graft so that way it has a higher chance of success of integrating into the recipient site. So graft mobilization or graft mobility can be the kiss of death. So earlier we talked about the black triangle being a kiss of death for aesthetic failures. This would be a kiss of death if you have graft mobility. The graft will have a much higher chance of failure if it moves, and we want to immobilize it. So autogenous grafting is a great way to regenerate bone, but it's not without its disadvantages. So already implant surgery is creating injury to the surgical site. When we consider an autogenous graft, where are we going to take the graft from? So sometimes it can be the ascending ramus, the external oblique line angle, the anterior mandibular symphysis, or the maxillary tuberosity. Those are all possible autogenous bone grafting donor sites, but we have to consider what are the post-operative consequences of taking bone from those donor sites. Then there's allogenic bone graft. This is our main workhorse, or the main type of category of bone grafting that we're using in my practice. And I really enjoy using this graft material because it's very predictable. Once you use this material frequently enough and you develop your own sense of comfort with using this graft material, you'll see what works and you will see what does not work through practice and use of this grafting material. So what are the benefits of allogenic bone graft or allograft? Well, it's great because we don't have to take the bone graft from a donor site. This comes packaged, sterilized, and is vetted for predictability and that it would work. Also, it has this property of osteoinductive potential, meaning it has growth factors that come from the cadaver donor for the bone graft. Osteoconductive, meaning it has a matrix form to the graft material, which will help guide the osteoblasts and osteoclasts and osteoprogenitor cells to lay a foundation for new bone formation, for woven bone and lamellar bone. There's also notable that not every tissue bank that provides you bone graft is considered equal. Every bone grafting or tissue bank company has different standards they have most common standards are going to be infection control, but the quality of the bone graft that you receive from the tissue bank can vary from company to company. Another type of grafting material is xenograft. So this can be porcine derived or bovine derived or even algae or coral or even wood. Wood's a type of xenograft. I haven't personally used any of those types of sources for wood xenograft, but I thought it was interesting and preparing for this presentation that wood was a source of xenograft. So it's just basically osteoconductive. You won't really see any benefit with osteoinductive potential and definitely no osteogenic potential from either allograft or xenograft. And then there's synthetic grafts like calcium phosphate, glass ceramics, and these can be very beneficial for economical considerations, or maybe just because there was a small defect that didn't need a whole half cc of bone graft. This could be a good solution just to do some minimal repair. So in some cases, you might wonder, why would we bone graft at all? And Dr. Kim was mentioning yesterday, I believe, about Dennis Tarnell's research on when to graft and when not to graft, and you can find an advocate for almost any philosophy you want to follow, but it doesn't mean that they're always going to be what's best. So bone grafting, in my opinion, is a wonderful service that I can provide to my patients, because if I can help facilitate more bone growth, then why wouldn't I? I want them to have a successful, fast healing, and bone grafting is a wonderful way to achieve that result. So there are studies that do show there are significant collapses in bone after a simple extraction. So one study they did where they researched post-extraction bone changes in dogs and found that there were significant changes in buccal lingual bone deficiency after an extraction. So bone grafting is something that can preserve the shape and the width of the edentulous site and help make future dental treatment more predictable, whether it's going to be an implant or a fixed partial denture, a 3-unit bridge, or a removable prosthetic bone morphology is going to be preserved with bone grafting. So especially in the anterior aesthetic zone, this was a study that I found was very interesting, that was considering the maxillary anterior buccal bone thickness. And this study said it was measuring on the cone beam radiograph, the thickness of the buccal plate in cases that were equal to or less than 1 millimeter in thickness had a significant association with bone collapse without a bone graft. So in other words, considering a case where an anterior maxillary tooth was extracted, like a central incisor, and the bone thickness being less than 1 millimeter thick on the radiograph, removing the tooth and not grafting has been associated with a higher chance of buccal lingual bone volume collapse. And so those are higher risk cases where you definitely want to consider bone grafting to preserve the ridge shape. That ties into the phenotype Dr. Kim was talking about earlier, considering not only the soft tissue appearance, but also what's the bone morphology look like. Those are all considerations with soft tissue phenotype. So back to basics of healing. We have 6 phases to consider when a tooth is extracted. So first, obviously we know there's going to be socket filling with blood. Then the clot forms, which forms a matrix. So the clot forms that matrix, and that helps recruit the cells that are going to come in and start breaking up the fibrin that are in the clot, laying down a granulation tissue framework. and then that will set the stage for the next step 4 here with the vascular network, connective tissue forming, and then connective tissue starts to eventually turn into woven bone, which is the immature bone, and then we know that becomes into lamellar bone as it becomes more mature and complete healing. So that's the normal process. And with allografting materials, this is one of the bone grafting material families that are offered through ZimV, which we get all of our grafting from ZimV. The biomaterials are very high quality. We've used bone grafting from companies that are not affiliated with ZimV before, and I've been surprised that I do see variability in the bone grafting quality from different tissue banks. So each implant company has a different source for tissue banks. Sometimes they share a common source, sometimes they don't. And a lot of times they advertise, this is the cheapest, this is the lowest cost bone graft, very great, same thing that you get from here to there, it's the same thing. And that's what they want to tell you, that it's the same thing, but it's not the same thing. It's very important to do your research on where you purchase your bone grafting from, because the way that they process and test the bone grafting material matters. So one of the reasons I love buying my bone grafting from ZimV is because I know that they test all of the lots or the batches of bone grafting before it leaves the facility to go to your office. And so one of the ways that they test it is they can do either a biochemical assay, an ELISA assay, or they can plant that bone grafting material in a rat's thigh muscle, and they monitor it to see over weeks and weeks of time, does it form bone? And so they make sure that every batch of bone graft that leaves the tissue donor bank can do what they're advertising it can do. And if any grafting batch doesn't pass either the biochemical ELISA, the assay, or the in vivo study, they throw away the whole batch. They don't send it. So in other words, what does that mean on a clinical practice level? That means that in my office, I know that the graft I'm using has a higher chance of success as long as the patient's body decides to do what we're trying to let it do, because ultimately the patient's body will decide whether or not it will accept the graft material. The patient's body will decide whether or not the implant will integrate, and there's a lot of factors that I can't control, but I can help have some control over where I get my grafting from, and that's why I choose this grafting company. So there's also, my favorite family of graft to use from ZimV is the Puros allograft tissue, because it has the sterilization process for taking from the cadaver donors, and it's a much gentler process of sterilization. So both of these have very effective sterilization processes. This is the Regeneros allograft material, and they both use the oxidative treatment and acid washes and the low dose gamma irradiation to sterilize the tissue from the donor banks. But the Puros uses a proprietary method called Tutoplast, which is going to be a lot gentler of handling for the tissue. So they both get the job done, but my favorite is Puros because I like the handling characteristics of the graft as we're placing it into the extraction site, and also I like the radiographic appearance. I can see where my graft material is after I complete the grafting procedure. We always take a radiograph after that so we can see where the graft fills.
Sau
And
phẫu thuật ấy, khi mà chụp lại phim CBCT ấy, thì tôi thể nhìn được là tôi đã ghép xương đến vùng nào, bởi vì cái vùng ghép xương nó
So this is
xương
our
ghép nó hiện khá là
typical
rõ trên
recipe.
phim CBCT.
To keep it simple, we're
Đây
using
là
a 70-30 mix of Puros, cortical cancellous allograft, and for most of my cases, if I'm doing a graft then I'm usually either using a PTFE or a non-resorbable membrane or a collagen membrane, but it's just more important for me to get primary closure when I'm using a collagen membrane. And when I'm using a PTFE or a non-resorbable membrane, it's less critical to get primary closure because I can guide the tissue to regenerate into the edentulous site. So I'll show you some cases here shortly. But so far we've really talked a lot about allograft material, benefits of allograft being osteoinductive, osteoconductive, and that there's no donor site that I have to go and retrieve this bone from. And then also autogenous graft is wonderful, but there's a donor site that's involved, and so these can be factors that I'm considering before I choose the graft material. In some cases, it's very nice to have a patient that needs a wisdom tooth extracted, like Dr. Ed was talking about earlier this week. We were considering patients that need their wisdom teeth extracted but are also maybe ridge deficient in the maxillary anterior region. You can couple those procedures on the same day, because if we're extracting mandibular wisdom teeth, but we're also planning to do either ridge augmentation for the maxillary anterior region or implant placement, we can harvest bone at the same time that we're removing wisdom teeth on the mandibular arch and transfer that bone and fixate it to where we need it in the anterior maxilla. So thinking about those types of procedures and making more efficient for the patient are things to consider for bone graft. So this is just the written version of the recipe. We're going to show photos now of this case. And I presented this case before, but it's a good review to show just in my office how we would go through this process. So in this case, we're looking at extracting a maxillary second molar. I guess this would be tooth number 17. Did I say that right? Yeah, tooth number 17. Okay, here's our periapical radiograph. This is tooth number 17, and we see non-restorable caries in the mesial. And so our goal today is we're also looking at placing an implant in the site eventually, but for the day of, we're just going to plan to remove the tooth and to graft the site. So we're also looking at other risk factors. You can also see the maxillary sinus floor. That looks like it overlaps or touches the apices of the tooth number 17. So these are risk factors we need to consider before we go in to remove the tooth. What are some complications that we might see when we pull this tooth? Is there a possibility that when this tooth is removed that the maxillary sinus is exposed? Yes, there is. There's also a possibility that, when this tooth is removed, that the sinus membrane, the Schneiderian membrane, could be perforated. So these are factors that we have to consider before we just pull the tooth, and we have to know how we're going to manage those complications as they occur. So here's our method. We're using this instrument that I showed you yesterday. This is the straight elevator, what we call the luxator, and we're aiming it at the distal buccal and the mesial buccal line angles of tooth number 17, and we're not focused on luxating the tooth buccal and lingual. We're focusing moderate to light pressure into the PDL. The PDL is the only thing holding this tooth in the alveolar bone. As soon as we were able to sever those PDL fibers from the root surface of the molar, we can retrieve this tooth as atraumatically as possible. I'm doing quotes because this is still trauma. There's still going to be inflammation and swelling from this procedure, but the less swelling, the less inflammation, the less surgery time, the better. We don't want to spend 2 hours or an hour pulling this tooth. This needs to be an efficient, controlled procedure. So here we go. All right, so we mobilized the tooth, and once the tooth was mobile with this process right here where we're gently pushing on the mesial, the distal, and we're taking our time with this to wait until this tooth is moving buccolingually. Then we can retrieve the tooth with the forceps, and then we can evaluate the buccal bone integrity. So I'm checking this area with this minimal envelope flap to evaluate the buccal bone to look for any buccal bone deficiencies, any fractures, and so that way we can see our surgical site much clearer, and also trying to see the apex of that socket. So we evaluated, we did the Valsalva maneuver, where we did this in clinic on Monday and Tuesday, but when we're doing either a sinus 4 elevation or placing an implant and drilling our osteotomy, we want to evaluate whether or not we tore the Schneiderian membrane to the maxillary sinus. So one way to do that is a Valsalva maneuver, where you hold the patient's nose shut and you ask them to try to force air through their nose. And with the mirror placed right here, so while you're doing that, you place the mirror right over the socket, and if you see air that is either fogging up the mirror, or you see like blood or some sort of liquid that's spraying the mirror, you know that there is a tear in that membrane right there. So do the Valsalva maneuver and check to see if there's a tear in the membrane. Once we evaluate there's no tear, you'll see I'm measuring this non-resorbable PTFE membrane. And so we're checking to make sure that we can cover the surgical site and that we have enough length of the membrane to go beyond the buccal and the lingual plate. So the next step I do is, before I put my bone graft into the surgical site, I'm actually going to attach the membrane to the palatal mucosa. And one way to do that is I'm going to use the suture, and I start the suture into the palatal flap, and then I take this membrane and I enter from one side of the flap, come out this way, and circle back and go back into the same membrane. And then I continue the suture through the socket side of the palatal flap, and then I tuck the membrane into that palatal bone between the full thickness mucogingival flap and the lingual bone. This material with the non-resorbable membrane is very technique sensitive, because this PTFE membrane has to be as smooth and flat as possible to avoid complications post-operatively. Like with the soft tissue, if there's any wrinkle or crease or sharp edge pointing up into the soft tissue, then post-operatively, this patient will have a lot of pain if this membrane is left sharp. It has to be very, very flat and smooth against that bone. So this is probably one of the only disadvantages of this material. Well, there's a couple disadvantages, but one is that it has to be very technique sensitive. It has to be smooth against the bone. Then we tie this suture off here, and now the flap is, the membrane is in place, and then I can retract the buccal soft tissue here, and all I have to do at this point is place the graft into the site, fill up the socket, and see, I have my buccal bone exposed here with my retractor, and I have my membrane, and I'm going to tuck that membrane right into that pocket between the soft tissue and the bone, just like that. So then now the buccal mucosa is overlapping this membrane, and then I just use a horizontal mattress suture here, and then one interrupted suture on the mesial and the distal, and there's my post-operative x-ray. So I probably could have put just a little bit more graft here, but this was a 1 cc vial, and the socket was pretty large. So
cc thôi nên là tôi cũng hài lòng.
so that's the result. So this stays in there for, I let it stay in there for 3 weeks.
Tôi để này,
And
tôi
then
để,
in 3 weeks, the
bán
patient
sau quay lại
returns for a post-op
cho
visit
buổi kiểm tra.
where we remove the sutures and we remove this white membrane.
Bỏ màng
This
đi.
is all very easily done without any local anesthesia.
Thực sự quy trình rất đơn giản và không cần gây tê.
Very predictable.
Và thực sự là
Very
quy trình
predictable.
cái buổi hậu phẫu nó khá là đơn giản.
Another case where we have a non-restorable tooth number 46.
Răng 30 không
Yeah,
hồi phục
I'm
được.
getting better at those numbers. So, okay. Tooth number 46 here, first molar. Large
Răng 46
periapical
không hồi được.
infection.
Có một tổn thương lớn ở dưới
Non-restorable.
trẽ. Với tôi là không hồi phục.
Removing the tooth,
Bây giờ tôi nhổ cái răng này.
placing the membrane. Almost have primary closure. Not necessary, but it's nice if we can.
Đóng vào thì đầu. Nhưng mà tôi đã làm gần như vào thì đầu tôi làm
Another
cái ca này.
molar, tooth number 36. This is a failed root canal treatment, and patient elects to no longer do root canals. They want to do an implant, but for now they want to just graft and save the money for the implant. So this nice quality of the bone graft I can see here on the x-ray because it's mineralized. The mineralized bone graft shows up really well in the x-ray and shows me the extent of the grafting that we did.
Cái xương nó gần giống với cái xương thật. Đây sau 3 tháng. Tiếp theo là một ca.
This patient had pain on biting. Vertical root fracture is very common in posterior molar teeth that are root canal treated, especially with just bruxers, patients who grind. And then also, you can see on this radiograph, there is a line going through the buccal furcation. The patient elects to extract the tooth, and we placed an implant the same day. This is an immediate. I think the main difficulty here with this procedure is the technique. So not only managing the soft tissue, but also maintaining where that mucogingival junction is right here will help control where that keratinized tissue is going to regenerate to. And so I don't have to coronally advance this flap. I can keep it at the same level that it was before and allow the granulation tissue from inside of the socket to fill this area. And so in 3 weeks, when I remove this membrane, thought I had the picture next to it. In 3 weeks, when we remove the membrane, we'll see new gingival tissue forming underneath where that membrane was. So this is at the 3-month mark. We placed a cover screw, and then we attached a scan body. And in our office, we're using digital workflow. So this is our scan of the tissue. This is on the upper right-hand side. This is after we've uncovered the implant. You can see that area right here, we just take a 15 blade and make a mid-crestal incision here. And then we attach our scan body. But we have to make sure this scan body is a digital post that helps us determine the position of the implant. We have to make sure we take an x-ray to make sure that scan body is fully seated with the implant, because there's an internal hexagon that fits inside of the implant. And sometimes the scan body isn't fully seated and you have to reposition it, seat it even further, take a new x-ray, because this will determine how the crown is made for the implant. And there's our final restoration. This is a screw-mentable, full zirconia, CAD-CAM, mill, titanium abutment. Here's a patient. His name is JT. This is tooth number 16, and a non-restorable, failed tooth number 16, and he elects to extract this tooth. The clicker's not working. Oh, yeah, it might be working. So here's our radiograph. We can see that the tooth is non-restorable. And we also see the maxillary sinus. So this is another risk factor to consider, is where the maxillary sinus floor is located. very good. Okay. So this tooth looks pretty messy. There's a lot of decay in there. And even the soft tissue, like look at this soft tissue, how angry it looks, and there's all this decay in there. So this is going to be a very kind of bloody procedure. But same protocol. So pull the tooth, check, do Valsalva maneuver to check to see if there's a membrane tear in the sinus. Place the bone graft, place the membrane, place the sutures. This is at 3 weeks, the membrane's removed, and we can see all of this white tissue right here. So this white tissue is all this from the granulation tissue inside of that extraction site where the blood filled up through the bone graft, and the membrane that we saw earlier. This membrane protected those particles from being dislodged from the extraction site, and it guided this tissue to grow into this area here and over here. So this is our guided tissue regeneration. And so all of this new white tissue will become revascularized and then generate into keratinized tissue, which sets the foundation for a healthy implant restoration. So another case, mandibular first molar. This patient has not had a filling on any other tooth except one tooth. So when I see panoramic x-rays like this, where a patient has a cavity and there's no other tooth that has a cavity, I really have to change the way that I approach my conversation with this patient. So, for patients that have not had dentistry very much, maybe they've never had a cavity in their life before, they've only had one tooth that's ever had any issue, and this tooth has another issue, that's worth extra time for a conversation. This is good to change the way that you approach, treatment planning for your patient, because you have to know who your audience is when you're telling your patient about a recommended procedure or a diagnosis and helping them through this thought process. So this patient had pain on number 46. You can see there's large decay on this molar, and she declined a root canal treatment. I am all in favor of saving teeth. If the tooth is savable, I would love to help save a tooth. But ultimately, the patient has options that I have to inform them on. This is informed consent. So informed consent says your recommended treatment is root canal, build-up, and crown. Alternative treatment is to remove the tooth and either replace the tooth with an implant, replace the tooth with a 3-unit fixed partial denture bridge, replace the tooth with a removable partial denture or a flipper, or remove the tooth and do nothing at all. Those are the options. Those are the risks and benefits of each one, explain what they are, and answer all their questions. That is the full informed consent process. So this patient said, no, I do not want a root canal. I want to pull this tooth and I want to do an implant. So that's what we're going to do. This is a case where we used the same protocol, but we used platelet-rich fibrin. And I know this is something that I think Dr. Kim is speaking on later today, but PRF. Have you guys heard of PRF before? Raise your hand if you heard PRF. It's a wonderful thing. We've been using it in the clinic this week, Monday and Tuesday, and it's one method you can use. You can use it as a membrane, and in this case we used it as a resorbable membrane. And the other benefit of using PRF is that it creates the perfect clot because it's from the patient and it's accepted 100% of the time by the patient, and it adheres to the soft tissue that you place it into. So it creates a hermetic seal or a watertight seal where you place it. And so we did an immediate implant placement in this case. This is another alveolar-ridge bone grafting procedure where this is an older case that I've presented before, but this was at site number 25. And you can see on this cone beam right here is a cross section in this area in the middle where it's a buccolingual bone deficiency of 7
Khi mà chúng
millimeters
ta nhìn vào
and
cái
a
thiếu hồng ở đây, thì chúng
apical
ta sẽ
coronal deficiency
đo
of
cái thiếu
over
hồng
10
trước
millimeters.
là cái thiếu hồng
And so this is
khi
a
mà chúng ta
site
nhổ
where
răng
the
ra
patient
nó
is
rơi vào
interested
khoảng
in
chiều ngang
implant
nó rơi vào
therapy,
khoảng 10,
but
chiều
we
dọc là
have
khoảng
to
7.
create the bone foundation for a
Và chúng
successful
ta cần
implant
phải bảo tồn
placement.
cái phần xương ở đây
So
để
we have to
cho cái kết
rebuild
quả
this
đặt
bone.
implant sau này.
Here's our radiograph, and it looks like there's no bone here at all.
Đây là
There
một
pretty
ca
much
lâm
is no
sàng khác.
bone.
Nếu mà chúng ta không có một xương thì chúng ta sẽ có một cái thiếu hồng ở đây.
So with our edentulous site here, we can see
Khi mà
site
ở cái vùng
number
mất răng chẳng
25.
hạn, thì ở
There's a
răng số
small
25 này
area
thì
where it looks like maybe a fistula,
thì chúng
drainage
ta
of
có cái lỗ giò ở
infection.
đây.
We
Chính vì
create
vậy
a
mà nó có
lingual
ổ
line
viêm ở bên
incision,
dưới.
so we can augment
Và
and
khi mà
create
chúng
an
ta
apically positioned flap,
sẽ dành cái đường
and we
rạch
can
về phía trong một
evaluate
chút.
the granulation
Và sau đó
tissue
thì
that's
chúng ta sẽ
present
lật
in
vạt
that
và
site,
loại bỏ những cái mô
and
hàn
then
ở đây.
degranulate the soft
Và
tissue.
sau khi mà chúng ta loại bỏ cái mô hàn rồi thì
There we go.
chúng ta sẽ
And we attach our membrane, same protocol.
cố định cái màng với cái quy
Place
trình
our
đầu
bone
tiên.
graft,
Sau đó chúng ta
place
đặt
our
xương
sutures,
và chúng ta
we
khâu
place an
đóng lại.
implant at site
Và
number
khi mà
24.
chúng ta đặt cái implant cùng thì với cả ở phần phía trước đó.
And in 3 weeks, this
Nên là
is what
sau
we
khi
see.
mà chúng ta
So,
tháo màng sau 3
poor
tuần
oral hygiene, lots of irritation, but the patient was very cautious about not irritating this delicate work that we did, and so she just neglected to keep everything clean. But
và cái màng này
everything
nó
healed
sẽ
up
giữ cái mô mềm
nicely,
phía dưới nó rất là
and
sạch
so we're happy with the results.
và bệnh nhân rất là hài lòng với cả cái kết quả
So
này.
my instructions for the patient are
Và
typically
đây là
to
cái cách mà
rinse
tôi hướng
twice a
dẫn
day
bệnh nhân sau phẫu thuật.
for
Bệnh nhân sẽ
5
dùng 2
days
lần
with
một
salt
ngày
water.
trong vòng 5 ngày.
And they can
với
brush
nước ấm.
gently in the area, but I don't want them to use a water pick. A water pick turns into
Bệnh nhân
basically a
tôi sẽ không
pressure
khuyến cáo bệnh
washer,
nhân dùng tăm nước đâu,
and
bởi
it
vì
can
bệnh tăm nước nó
just
sẽ
move
có
all the
những
graft
cái
material that
áp
is
lực
in
rất
the
là mạnh
area.
và nó có thể
So I just want them to
làm
gently
chuyển động
keep it clean.
và làm trôi phần
Obviously,
xương ở
avoid
bên
chewing
dưới.
on that side too.
Nhưng mà ở
This is
cái
after
vùng
4
khác
months,
thì
4
bệnh nhân
months
vẫn thể răng
post-operative
miệng bình
cone
thường.
beam, and
Và
we
đây là
look
cái
at the
hình ảnh lâm
same
sàng sau
site
4
here
tháng.
at site
Và chúng
number
ta nhìn thấy cái
25,
phần xương
and we were
ghép
able
của
to
chúng ta
regenerate up
đã
to
được tái
9
sinh.
millimeters of buccolingual ridge width,
Có
and
được
over
chiều
10
cao với
millimeters,
cả
over
chiều dài
11
xương khoảng 10
millimeters
mm
of
rồi.
bone grafting
Với cái
vertically.
phần vật liệu ghép.
So this is with the same graft material that we use for all of our cases. It's
Đây
a
là
cortical
cái,
cancellous allograft,
tôi sử dụng,
particle size 250
cái phần xương độc
micrometers to
trùng cho tất cả
1,000
các ca lâm sàng của
micrometers, basically 1 millimeter. That particle
Hoặc là
range
trong những
size
ca lâm
works really
sàng mà
well
cái màng xương mặt
for
ngoài nó mỏng
most of my
mà
cases, and that's
có dùng
why
cái vật
I've
liệu ghép
limited
này.
my inventory to only a few main bone grafting materials
Thì tôi
because
sẽ
it's so useful.
sử dụng cái vật liệu ghép này bởi vì nó rất là hữu dụng.
So just key points that we talked
Đây là
about,
những
we're
cái,
trying to limit the
để-
trauma in the extraction
để chúng
site.
ta
We want to keep the
bảo tồn
surgical
cái độ
site
răng.
clean. We want to
Chúng ta
remove any
sẽ
granulation
răng,
tissue from
răng
the
trần.
failed
Sau đó thì
tooth,
chúng ta sẽ
clean it with
loại bỏ những
saline,
cái phần mô
and
hàn mô
then
viêm.
use the same recipe that we've
Và
been
sau đó
showing
bơm
where,
rửa.
it's repeatable. You don't have to worry too much about what goes next whenever you're doing things in a repeatable way.
Và khi mà chúng ta bảo tồn được răng rồi thì chúng ta sẽ rất là dễ tiếp cận, không phải
Here's another
quá
case
khó
where
về cái cách tiếp cận
just
sau này.
a failing tooth, number 24,
Trên
and
cái
large
răng số 24
periapical
này thì sao?
lesion here.
Thì
We
chúng
can
ta
see
có
on
một cái
this
tổn
cone
thương ở
beam,
đây.
we're evaluating
Trên
the
cái ca
buccal
khi trên
quality.
cone beam thì
There's
chúng ta sẽ
no
có một
buccal
khối
bone
khớp rất là
that
lớn.
exists at the apex, the
Và
buccal or the
chúng
lingual
ta mất
of
cả
this
bản
tooth.
xương mặt ngoài mặt trong.
And so this is
Còn
going to
xương
be
ở
a
vùng trong
very
thôi.
difficult
Thì
case,
trên ca
but we
lâm
can
sàng này là một
see
ca khó rồi.
there
Và chúng
is
ta
a
sẽ
lot
thấy
of
rằng
room for bone growth.
chúng
One of the
ta
key determining
có một
factors
cái
of
tiềm
what
năng tốt là
areas can be
nó có đủ
regenerated
cái
with
không gian để
bone
cho cái
are
xương nó
is to
hình thành.
look at the neighboring teeth.
Bởi vì khi mà chúng ta nhìn
Where
vào những cái
does
răng bên
the
cạnh
alveolar bone
thì chúng ta thấy cái đỉnh mao xương
extend
của
to
hai
on
cái
the
răng bên
mesial
cạnh
and
nó
the
vẫn
distal
còn ở
tooth,
phía gần và phía xa.
and where are the sources
Vì
of
vậy
blood
mà,
flow? So bone graft has to have a
cái xương
blood
nó sẽ hình thành từ
source.
đó đấy.
So just because I put bone graft in an area, maybe vertically on top of a bone ridge right here, and put a collagen membrane over it, I can't really expect that bone to grow. I have to consider where are the blood sources, where's the nutrition source coming from. If I remove this tooth and I place bone
Và
graft,
khi mà chúng
it
ta
has to have a
răng ra và
source
chúng ta
of
đặt xương vào
nutrition,
thì chúng ta
of blood,
sẽ có một cái cục
so
máu
that
đông ổn
things
định.
can heal predictably.
Và cái ca lâm sàng này nó sẽ đem lại cái tiên lượng tốt bởi vì hai cái răng bên cạnh nó vẫn còn cái xương.
So here's our step by step,
Thì đây là các bước quy trình khi mà chúng ta làm.
and we have flap reflection,
Thì chúng ta lật
and
vạt
this
một
was
phía.
our yellow dotted line was our incision line. We created a sulcular incision
tạo
here.
ra cái đường rạch ở đây. Trong đường rạch đi trong rạch lợi đấy.
And this is our extraction site.
Và chúng ta sẽ
We
đổ ra.
pulled the tooth, and then over here is the buccal bone. A very thin amount of buccal bone is present here because there is an apical fenestration on the buccal area.
Có một cái tổn thương cả
And
phía
then
trong nữa.
inside of the socket, everything looks the same. Everything looks red. It looks mixed white and red. So it's hard to see the difference between hard tissue and soft tissue unless you're irrigating copiously with saline. So saline is, if I can't see where I'm at, then I irrigate with saline, just continuously. Irrigate with saline. That's the only way I'm going to be able to see white bone versus granulation and infection tissue.
Thì chúng ta sẽ dừng lại.
So this area, this dotted line, that's the bone, that's the autogenous bone right there that dictates, it sets the fate, like what Dr. Kim was saying earlier. Bone sets the tone, tissue is the issue, but the buccal plate sets the fate. And so this buccal bone right here, this buccal plate will create the scaffold or the shape of this socket. Another thing is to note, how thick is that buccal plate? That looks at least, maybe it's from the angle, but it looks like it's at least a millimeter thickness. So this is a high predictability of regenerative success. But we have to make sure that we clean this extraction site meticulously. It's not clicking over. There we go. So we clean and we clean. Here's the buccal wall over here. This is my metal retractor. This is the buccal plate. That's the palatal wall. And we're irrigating, but if you look closely, there is some granulation tissue at the apex here. I know this clicker is giving up on me. Go. Clean again. Clean again. Clean again. Preserve that buccal bone. Don't tear it away. Clean again. Clean again. And just when you think you've cleaned everything, you take your Explorer and you check the walls and you find even more soft tissue stuck to the bone somewhere. So you have to clean this off so that way you have a higher bone to implant, bone to bone graft contact. And you reevaluate. So now we see white bone, we see blood perfusing in. This is our graft source. This is where the nutrition is going to come from for the bone graft. So this is important. We have to make sure these are bleeding bone walls, so that way all of these sources of cancellous or bone marrow are able to feed into the bone grafting site. So this is the palatal wall. We're using the same recipe for guided tissue regeneration. This is where I'm going to tuck that white PTFE non-resorbable membrane. Yeah, thank you. Yeah, so we're still evaluating. We're getting nice dissection of that soft tissue off the palatal wall. And we're tucking the membrane. It has to be very flat against the palatal wall. This was such a large defect that I actually took two membranes and stitched them together. So that's why you see some of it is flapped over right here. And we didn't have to achieve primary closure here. And so that's why we use the PTFE membranes. You don't have to get primary closure. And we stabilized. There we go. So platelet-rich fibrin, we can harvest this from the patient's own body and do it through a blood draw. We did this on Monday and Tuesday this week. And the wonderful thing about platelet-rich fibrin is it's loaded with growth factors from the patient's own platelets. So in the centrifugation process, there is a process of density separation where the blood is drawn from the patient's arm. It's spun in a centrifuge, the LPRF, leukocyte-rich, platelet-rich fibrin process, and it separates all the cells and liquids based on density. So at the very bottom of the PRF tube is the hematocrit, which is all the red blood cells. And then in the middle is what we call the buffy coat, where it transitions from the albumin and platelet poor plasma at the top of the test tube, and in the middle zone is that's where all the good nutrients are that you really care about for healing in bone regeneration, and it accelerates the healing process because it takes all the growth factors from the platelets and it concentrates them into one site. So that's why we really love PRF, is because it bypasses the inflammatory process from an extraction, where when you have swelling, the swelling is a reaction to trauma. Swelling delays wound healing. Platelet-rich fibrin concentrates all the good nutrients in the platelet cells into one specific site. So you don't have to wait for inflammation to diminish. You can start the healing process a lot faster. And this is something that is really beneficial for all patients, but especially for patients who are medically compromised, considering all my diabetic patients, or patients who are smokers who have just less vascularization in their mucosa because of history of smoking. So PRF is something that is very useful for that category. Yeah, so we talked about this already. Accelerates wound healing. It's the perfect blood clot. This is us. This is a video. It plays. There we go. So we're taking the PRF from the test tube. I think this is from when I first started using PRF years ago. But we have a press plate, and so we can see the top part, which is that yellow part, and then this red part, which is the hematocrit. This is all stuck together, and it looks very strange, but this is beautiful. This is going to help us regenerate the soft tissue and accelerate wound healing. So once we press the PRF, then we're left with this membrane type of consistency. And so all of the growth factors from the platelets are concentrated at that zone between the yellow and the red right there. And that's the first side that goes into the socket for me. The top part is the yellow part. That one can be closest toward the soft tissue. But this can act as a grafting material. I can use this as a sole grafting material. Bless. There's also liquid that's coming out from the site. That's why we have the gauze right here to absorb it, so that way the patient doesn't swallow it. There we go. So the most common sites to draw blood from are going to be the cephalic vein, and it can be difficult to find these veins on some patients, but I found this, I told Dr. Coletti this last year, I think. We use this vein light finder, and it helps for certain sites where it's hard to see where that vein is, but also feeling where the vein is an easy way to do it too, just knowing where to feel it from. Okay, so I think we're coming up on the end of my time here, but we have more wonderful presentations for the morning and the afternoon, and I hope this was helpful and useful for everyone to see different ways to graft bone and regenerate sites.
Hy vọng là cách bài trình tôi sẽ cho mọi người nhìn ra được cái slide là một tuần sau ghép bằng PRF.
Okay, so we're gonna take a break in a moment. Does anyone have any brief questions?
Ai có câu hỏi nào không ạ? Sau hai bài báo cáo vừa rồi.